list, which we certainly hope you will. It's your implied permission to be part of a recorded educational activity. The program this evening provides 1 hour Category 1 Physician CME credit and 1 hour of Virginia Nurses Association CE or continuing education credit. Sovah Health is an accredited member of the Southern State CME Collaborative, an ACCME accredited organization. Similarly, Sovah Health is accredited by the Virginia Nurses Association to provide nursing CE credit for our programs. The program this evening is designed to promote several desirable physician attributes, including our providing patient-centered care and employing evidence-based medicine in our practice, and illustrating and demonstrating professionalism in all that we do, including our promotion of diversity, equity, and inclusion of all in the care system and among our patients. Dr. Tobe, myself, Ms. Sturdivant, and members of the Sovah Health CME Committee have nothing to disclose as far as commercial relationships over the past 2 years. Similarly, there is no commercial support for this activity. It is supported, as is the case of all of our CME programs at Sovah Health, by an educational grant from the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. Dr. Landis, who founded the Southside Urology and Nephrology practice, or previously known as the Danville Urologic Clinic, established this endowment or this fund for medical education throughout our care area here in Danville and Martinsville. And because of his generosity and forethought, we're able to have programs such as the one we're having this evening. This evening, you will receive by email a program evaluation. You also can access it, and I'll show you in a minute with a PCR code. That evaluation form will ask you to enter your name and your email address as you did when you registered. Please give us your full name on that evaluation form registration, because the CME certificate that you'll subsequently receive will utilize what you put in on the evaluation form. If someone's with you tonight, watching or listening, participating through your logon, please let one of us know that, myself or Mary Kent or Van Holt, so that we can be sure whoever else may be with you gets credit for their participation. Evaluation forms are not required for CME credit for the physicians on the call. However, they are required by the Virginia Nurses Association for nursing CE credits. Mary Kent will put into the chat towards the end of the program a QR code, if you like to use that rather than waiting for the email to come, that you can click on, and it'll open the evaluation form for you. We like to remind our residents on the call, and there will be a lot of them on the call tonight, that your participation this evening is tracked by your respective residency coordinator, Dara Johnson or Lori Galvez, so you do not have to keep up with CME certificates for that purpose. Otherwise, once the eval form is received, you will receive electronically a CME certificate or CE certificate of your participation. And again, I remind you that the evaluation form is required for credit for nurses and nurse practitioners. I like every time we do a program to thank Mary Kent and Van Holt for their help in developing this program, and also for this particular program, Leslie Sturdivant. Without their planning, foresight, and just doggone hard work in the sense of the documents and the many things that we must do to produce the programs, we wouldn't have the program. So thank you so much for all that each of you do and have done to let us have the program this evening. I know Dr. Tobe wants to have interaction, chatting about topics, particularly the topic we have tonight is always helpful, and we learn from it. If you want to ask a question or make a comment, you can speak up or raise your hand in the chat, and Mary will forward that to Dr. Tobe. Once you ask your question or make your comment, please mute your phone so we don't get feedback. You're more than welcome to ask multiple questions, multiple comments. We encourage you to do that. But if you will mute your phone, it just makes for if you will, a more pleasant dialogue so we don't get the whistling feedback. I want to highlight a program that's going to be coming up. It turns out, and we sort of realized this in retrospect, but in the month of March, we're basically doing, if you will, OBGYN centric programs. Actually, we're mainly doing maternal health. So not only the program this evening is to that purpose, but in 2 weeks, we will have what I think is a very special program on gestational hypertension, preeclampsia, and eclampsia. The prevalence or the incidence, the number of women experiencing preeclampsia has been steadily increasing over recent years, so that the early detection, which is something that if you do can help treat and manage the elevated blood pressures and potential renal involvement with eclamptic syndromes, is something that we want to make people aware of. Dr. Philip Onea, who's one of the OBGYN physicians here in Danville, and Dr. Promise Obianzi is one of our internal medicine residents. They'll be bringing the program to you, and I hope you'll be able to attend. That being said, I'm delighted that Leslie Sturdivant, the Vice President of Sovah Health, who manages our support services as well as our diversity, inclusion, and equality efforts, is going to moderate the program. Leslie has been a wonderful leader in so many things at Sovah Health, and her bright, enthusiastic, energetic approach is so appreciated. It makes such a great difference in our being able to provide the best possible safe patient care. So Leslie, you may go right ahead and begin introducing Dr. Tobe. Dr. Tobe, if you'll bring your slides up, mine will drop off. And thank you both for your efforts this evening. Thanks a bunch.
Good evening, everybody, and thank you so much, Dr. Moore. And first, let me just thank Dr. Moore and Mary Kent for constantly doing the heavy lifting and bringing such excellent and wonderful CME programs, not just to Sovah, but to our partners and to our health professionals throughout the region. So welcome, everyone, and thank you for joining us today. It is truly a privilege to gather this evening, for the CME session focused on health equity and maternal health, a topic that is central, truly central to our mission and our ongoing work as a health system. Here at Sovah Health, our commitment to advancing health equity is a cornerstone of our values and our strategic vision. And today's CME is an important part of this ongoing journey. And at this time, it really is my pleasure to introduce Dr. Cardi Tobe. Dr. Tobe is board certified in general cardiology, nuclear cardiology, echocardiography, cardiovascular computed tomography, and internal medicine. As a non-invasive preventative cardiologist, her areas of interest include cardiometabolic disease prevention and women's cardiovascular health, with emphasis on cardio-obstetrics. Her global research interest includes understanding the impact of social drivers of health on clinical outcomes and helping to create ways this can be addressed appropriately. She also focuses on reducing disparities in access to healthcare in medically underserved populations. Dr. Tobe is currently the medical director and the founder of the Cone Health Heart and Vascular Cardio-Obstetrics Women's Heart Health Program. She also serves as the clinical integration officer with Cone Health Center for Equity. There's the Health Equity Champions Committee. I love that. In this role, she focuses on developing strategies to improve access to care for individuals from medically underserved and under-resourced backgrounds. In her leisure, like she's got time for leisure, she enjoys spending time with her family. She is married with 2 young daughters. Her natural passion for fashion and style has led her to be the creative director and founder of the brand Tobe Stars, which features authentic, beautiful, handcrafted leather handbags using traditional African fabrics. Please help me welcome Dr. Cardi Tobe. Take it away, Dr. Tobe.
Thank you, Leslie. I appreciate that kind introduction. And before I start, I want to extend my appreciation and thanks to Dr. Moore and Mary Kent. I appreciate you guys inviting me And I want to thank all of you that are on the line for us to have this conversation today. So please, as Dr. Moore said, raise your hand, ask a question. This is crucial that we have this conversation and answer each other's questions and learn from each other today. So without further ado, I'm going to be talking today on one of the things that is near and dear to my heart is maternal health and making sure that every woman that we encounter in our different environments have access to equitable and accessible health care in terms of their reproductive years and beyond. So it takes a village. I have no pharmaceutical financial disclosures to here that I will be talking about today. There will be no commercial. I'm not going to be selling any medications or drugs to you or promoting any policies. I just am going to present what we need to talk about. So my goal today, and I hope that we will talk about, first of all, understand the basis of terminology. So when you're looking at the literature when it comes to maternal mortality, you can understand what things mean. Second part of it is look at the world at large, because even though United States, we have a high number, but the world is suffering too in terms of maternal health. Come down to our country and then a little bit talk about, Virginia, what I've learned just looking at the data interstate, as well as what are the leading causes of these deaths and what can prevent them, and mainly focusing on what can we do as the medical health system to help to intervene on premature death in women in our society. So I like to go to maternal mortality. And when we talk about this, it's not just the time of pregnancy or the time of childbirth. That extends up to 1 year postpartum. And that could be either what we call pregnancy-related death or pregnancy-associated death. And when you start thinking about pregnancy-related death, you're thinking about complications that happen during the pregnancy that has led to the death of the person. And pregnancy-associated death could be other things, for example, like a car accident from a woman who has had a baby within that year postpartum, and the assumption is she probably fell asleep as she was driving, or there may have been a sudden cardiac arrest that could have led from either something in terms of electrolytes or something, but the goal is, or the definition really lies on what we're talking about in terms of that 1 year postpartum. Now, we start thinking about the ratios, and when we talk about the numbers, when you're looking at anything the CDC will put out or the Maternal Mortality Review Council, we have the numbers are usually look over 100,000. So the ratio that you will be looking at for those numbers will be whatever number is reported that year over 100,000. So that makes it understandable a little bit. Preventability. Most of what we would talk about here today, maybe outside of certain infections or acuities, really can be prevented when it comes to maternal care, when it comes to the reproductive health of a woman who has just had a baby, when it comes to morbidity. So those are the things that the Maternal Mortality Review Committee, where in Virginia it's called the Maternal Mortality Review Team, looks at on an annual basis and look at these things that are either preventable, that are pregnancy related, things that we can intervene on to reduce our maternal mortality rate. I'm going to show you in a few minutes how we stand as an industrialized country in terms of all of our superpowers, but when it comes to maternal mortality, we're pretty low on the food chain there, thinking about start looking at third world countries, really, when we start thinking, because we're not near Canada, we're not near France, we're not near Australia, we've still got work to do, and we're going to talk about how we can make a difference today. So I want you to think about this and think about what 2 minutes means to you when you have to get to work and you have 2 minutes and just in time you get to the light and it's red. And it can feel like eternity, especially for those people who really have bosses that are are not forgiving, or for physicians and clinicians and healthcare members, we're probably trying to get to that procedure. 2 minutes mean it can be a long time, but at the same time, it can be a very short time. Thinking about every 2 minutes worldwide, we're going to lose a woman of reproductive age due to something that's possible preventable. And that's something that is a hard thing to think about. And we're talking about in the whole world. So that makes that difficult for us because we're encouraging, reproductive. We're encouraging women to have more babies. We're encouraging people to really grow, expand their family. But at the same time, we think about data like this, and we think about looking at, you don't think having a baby is actually a time of sorrow, but it could be, depending on things that we don't prevent. So I want to share with you some of the data that have come up since 2020, looking at numbers for just across the board in the world. And you think back in 2020, we had 287,000 women that died either during or after childbirth. Now, there could be lots of reasons, including countries that are not industrialized and not using sterile techniques, so infection becomes a big deal. Talking about people that may have had significant obstetrical complications and they don't have access to a physician for immediate C-section. So you're talking about multiple possibilities. But then we start thinking about access, because that becomes an issue there. We start thinking about the causes, and we start thinking about how can we prevent it. Now, we started to look at that same data reported in high-income countries and low-income countries, and you'll see that it's obvious that low-income countries are going to have higher death rates because of the reasons that I had talked about earlier, and we're talking more technology now, with the complications and no OBs, or people that are not capable or to do surgeries, and they're mostly midwives and house delivery. So a lot of other things that can happen. And then we start looking at industrialized country, 13 per 100,000. If you think about it, that's still a large number. And we also have to think about what's happening in the developing areas. Resources is one of the big things. 90% of what maternal death turns out to be is resources in certain way, access to care, either, and we will talk about it in a minute, social determinants of health in terms of financial needs. And then we start talking about things like lack of resources because likely implicit bias. So all those things come in play when you think about maternal health. Now, I mentioned a little bit as I talked about the numbers and talk about the leading causes. When you look at it worldwide, look at the maternal mortality report back in 2024. The leading cause worldwide is hemorrhage and infections. We talk about complications during delivery and unsafe abortions. Now, most of these deaths are preventable. And if you're looking at access and thinking about interventions with resources. Now, to reduce these numbers, one of the things that we start thinking about, and we're not talking solutions now, we're just generalizing what we could potentially start thinking about as we go to the conversation that's going to spark questions, going to spark comments. We think about what is the reliability? How do we really deliver antenatal care in different places? How do we really get skilled delivery during those times? And are there even good postpartum care? So those are the things we start thinking about. But however, when we looked at the low-income countries versus the high-income countries, it really comes down again to resources. So these are the things we start thinking about. And then we cross over to our own country, the United States. So among the industrialized country, the United States is very, very high in terms of maternal mortality when you think about it. The other thing I want to bring to your attention is the racial disparities in this, the Black and white disparity. And yes, some may say, how about rural women? Rural women does have a lack of access, and there may be the increasing number, but it's a huge gap when it comes to maternal care. And I would like to share with you that even me as an educated woman, however, when my delivery risk is high in terms of mortality because of my race. So despite, there was a study that was done a couple of years back in New York looking at educated Black women compared to women of Caucasian descent with high school education. And when I say educated Black women, I mean women with master's degrees and beyond. And still that disparity was there. So we can appreciate that race plays a factor. And then we start thinking about what are these leading causes? We've talked about one and we'll talk about others as we go ahead. The trend that we have in the US from 2018 to 2021, the other thing I want to point out today is our data lags at least about 2 years. Some countries, they're so good with their data that they're able to at this time in 2025, they have their maternal mortality data from 2024. So there are immediate action that they can do to make the difference for the next year. Now, we tend to react because if we're looking at 2021 data in 2023 and we're looking at 2023 data in 2025, it really, because some of the things that may have been essential at that time are no longer important. So if you think about 2020 and the COVID pandemic, we didn't hear anything about that data until 2022. Well, there are some things that have changed. So we need to do better as a country and think about how we can do better to be able to get interventions ahead of time to address the issues that we're having. So I'd like to share with you here, when you look at the numbers from the bottom, US is not on the top because of the Olympics, and this is gold medal. I'm telling you, we are doing poorly when it comes to maternal mortality. This top number here means that compared to all of these industrialized countries, and if you can see the highest being France, 8.7, we're likely slightly doubled, and a little over with our maternal mortality. And we start thinking about what's the reasons. A couple of reasons in the United States, our C-section rates are high compared to some of these other countries. We start thinking about inadequate prenatal care. That's where the access to care come in, and start looking at the racial disparities and start looking at urban versus rural women and start looking at health literacy. Also think about what I do, chronic illness, cardiovascular disease. We have significant burden of cardiovascular disease, and a lot of times women are not optimized with their cardiovascular disease before they get pregnant. A lot of times women are waiting later years to get pregnant, so they've developed hypertension, they've developed diabetes, they have gotten other things that needs to be optimized. Hence, if for any primary care physicians on this call, you have a part to play in maternal mortality and morbidity because you are the gateway to asking your reproductive women, listen, are you interested in having a baby in the next year? And start thinking about them, prompting them about what medications they could be on, what their sugars look like, and how it can get better. Their blood pressure is 140. Can we get you down to 130? And have those conversations of possibilities, and then get either the OBGYN or a cardiologist on board. Not all cardiologists are made equal, so some will be comfortable with getting care of the maternal health or the reproductive age women, or you get a cardio-obstetrics or cardio-obstetrician like myself on board, making sure that the prenatal counseling is important. I cannot stress that enough. And then we start talking about OB partners. What are you doing with thinking about when they're here now? What are some of the things? You can't just take them off Maternal because that, please replace it. Make sure do not wait. The data is different when it comes to hypertension, when it comes to what the numbers are. We're not agreeing on quite yet, but there are some data that are coming that 140/90 really is the number. So we have to be very careful for that early stage hypertensive stage in pregnancy and gestational hypertension. Also, missed or delayed appointments or treatment. That's when we start thinking about their access and what are the things. So these things have been noted and documented in the United States that these are the problem areas. Now, I think one of the biggest opportunities that we have as we have this conversation, how do we make it different for our service areas, the people that we take care of? Because we can't make it for the country. But when we do that and we're successful, then we can share that data with who's looking. You can share that data with next door, Maryland or North Carolina, West Virginia, and people start to shift and mindsets start to change. United States, I have just shared with you that Black women will face 3 times more mortality than their white counterparts. There are data for Hispanics. If you see here, you look at the numbers and you see that was reported back in 2023. So I'm giving you recent data. Someone may say, I just saw something from 2025 that is telling us shifting gear. Maybe, but is it really something that's randomized? Do we have more information? Who's writing this? So we have to be careful when we look at data, and we need to be able to understand. And when we do these things and have these conversations, I would like to point out that it's not shifting blames. These are conversations and these are discussions of possibilities, because once we're able to really face head on what the problem is, we have an opportunity to be able to discuss what our solutions can be. So our conversations of possibilities sometimes can be difficult. Sometimes it's something that we may not want to hear, but it's a conversation that needs to happen. Why is this for Black women? We look at these things. I talk about high chronic conditions in terms of cardiometabolic risk factors are high in Black women, especially the older you get, closer to 35, the likelihood for early diagnosis of high blood pressure, early diagnosis of diabetes, and because of risk factors optimization. The other aspect of this is variation in healthcare. We start thinking about the social determinants of health. I want to tell you today that 80% of what we do is not what the physicians do or the outcome for the individuals. Our contribution is about 10 to 15% for the outcome of what an individual does. About 75 to 80% is based on social determinants of health, and that also is including a family history. So you can say 10% out of that and 70%. But start thinking about health literacy, built neighborhoods, access to care, thinking about financial issues for the individual, homelessness, And then we go back to structural racism, which actually extends into built neighborhoods, because when we start having conversations of opportunities and looking at historical hello and looking at historical conversations for structural racism, implicit bias. So things like that, really, we need to have these conversations and be able to appreciate what our next steps are. So with that, I'd like to share with you that within the United States, we've talked about the racial disparities. We've talked about what's the #1 leading causes of maternal mortality in the world. Now let's come to our country and face what we're facing here. Cardiovascular disease is the #1 reason why a reproductive age woman is going to have a complication and is going to have death. So if you look at this graph here that was reported back in 2019, we really don't have an updated one, but the data will not change. The numbers may not change. If you see that here, as I'm showing you, cardiovascular conditions, and then they talk about cardiomyopathy, hypertensive disorder in pregnancy, and cardiovascular accidents. Like, come on. What you're spreading it out, and what it really ends up being is all of this is under the bucket of what I take care of, cardiovascular disease. So if you think about all of these, it's 38%. You spread it out, you put it together, it's 38%. But what I do appreciate, though, is the fact that we can look at it separately and talk about peripartum cardiomyopathy, talk about hypertensive disorder. Is it chronic? Is it gestational? Is it postpartum? And see what we do about it. And then we come down to sepsis and hemorrhagic postpartum hemorrhage, and we talk about thromboembolic effects like PE. And then, here I just left it down here because give or take, you can argue all day and say, oh, hypertensive disorder pregnancy is on its own, but I usually put it there so people can really see that while it's in that bundle up there, it can be separately by itself, and just by itself, it speaks volumes that the #5 reason is hypertensive disorder in pregnancy outside of the other aspect of cardiovascular disease. So that is a lot. And that's why when we have conversations of possibilities with cardiologists like myself who take care of women of reproductive age is really important to us. And we take time to have these conferences and take time to give you the information that we have and we've seen either based on clinical research or anecdotally with patients that we've taken care of. So I'm so excited to have this conversation with you all today. So
hey,
one maybe,
yes, ma'am. Can I ask a quick question? Go back to that previous slide. Just ask a quick question. Mm-hmm. Is the cardiovascular disease being the #1 cause, is that specific to ethnicity, or is that just like general across all?
It's general across all, with women of African descent having the highest burden.
Okay, thank you.
Mm-hmm. You're welcome. And thanks for bringing us to that for clarification. All right. Timing. So everything is timing when you think about when you're going to get that next job, for the residents on the call, when you matched, right? It was all timing. And when you rotated to the place that was your number one choice, when you got that first job, your house and everything. And that's the same with everything in any clinical care. So when we look at time of death, it's kind of spread across this pie graph here and all complications. When you see that this data is from 2017, however, we don't have anything better, but this still represents, and when you look at data in different sectors, and I would actually encourage you to look at your data in your hospital and see what's going on there. But before women deliver, usually within the antenatal state, they can be about a third for risk of death during that delivery. And I'm not encouraging any woman on the call who is anticipating their pregnancy, but I'm just trying to assure you that these things can happen. However, we are able to intervene and care for you once we're able to do that. At the time of delivery, there is also a risk. And then at the time of their postpartum phase, during the first week, that's the time. And we've seen our data showing that, especially when it comes to postpartum hypertension, between day 5 of discharge, not delivery, really. Discharge is when day 5 to 7 women come back with postpartum hypertension, and we're trying to figure out ways that we can intervene because it causes two major problems. One, separation from the baby, two, mother at risk, and then separation from the baby can cause either stopping breastfeeding, which the baby really needs, or depression in a mom. So these are things that we have to be conscious of. And wanted to share with you again, looking at how are we doing over years. So like I said, 2023, so hopefully by 2025, we can get new data. 2023, that's the most up-to-date data we have in the US right now of the trajectory of the ratio of maternal mortality. So think about that over the 100,000 that we talked about. So now you're looking at that number in 2018, it went up. And yes, COVID-19 had something to do with it as well. But we're going up. That trajectory is going up. And in 2021, 32%. So my curiosity is all of the work that we're doing and all of the conversations we're having, and really when it comes to social determinants of health, we really started looking at this as a nation somewhere around 2020 when you think about the George Floyd incident and you start thinking about healthcare, when we start thinking about a COVID-19 infection, that's when we really saw that the social drivers are, not that we didn't know that, but we really saw that changes with CMS and saw the difference in the tune of how do we really address this, and this becoming a medical, not just an issue that is here and I write a prescription. It's becoming a medical intervention that we can be able to make sure that individuals get care. So I like to talk a little bit about Virginia. And yes, our data in North Carolina are not that better. So if you're asking me, I'll say, it's not that better. But I'd like to really bring to your attention, if you've never seen your maternal mortality review report. This is from last year, 2024. As you can see, back in 2021, something good happened, but in 2022 it went up. And then we started looking at the numbers by, not by much, but the idea here, the trend's going up when we talk about deaths. And then pregnancy associated deaths, same thing, 69, and then 2022 went up. What I want to bring to your attention is the age gap. We look over 35% of pregnancy associated death involve women the age of 35 and older. So these are young women. So we have to start understanding why we may be, for lack of better word, failing our young women, how we're not intervening before we get to the aspect of death, because then we're breaking down multiple social structures. Mom's not there anymore. Kid doesn't have mom, dad may be left with that, or if dad's not in the picture, the family is left with grandparents. So it really it develops a very complicated structure in terms of the social aspect of things. And then again, when you think about considering high-risk pregnancy, women over 35, not because of advanced maternal age only, yes, that plays a role, but most women may have one either risk factors for chronic disease, metabolic syndrome, other things in terms of hypertension, or yes, advanced maternal age exposes them to that during pregnancy, developing gestational hypertension. And another issue is we do have women who are obese that are having baby, and that creates also another complication there. So here, I broke this down as I was reading your data, and I learned a lot from this too. I was reading your data. Highlighted in red is the southwestern part of the state, and I was projecting that's where Sovah Health sits. So as you can see that per live births, 87 per live birth that's happening in that region. However, if you look at the highest areas is the 96 here, and that was the northern region. I think it's a typo here. It's a northern region of Virginia. But if you want to get more on that, you can get the Virginia Maternal Mortality Review Team report from 2024. Now, go through a little bit of what that team, so that team includes multidisciplinary individuals. So some are not physicians, some are community individuals, some are law enforcement, but there are a few factors that I'm just going to go over that they pointed out for pregnancy-related death. One was talking about the percentage of women with facility-related factors. So they started talking about lack of facility for continuation of care. So that actually really captures, are there enough physicians or care providers, or I'll say clinicians, because when we talk about our APP counterparts, our advanced practitioner counterparts, and the midwives, and are there enough practitioners to care for women during a reproductive age? And are there adequate services? Because we have facilities, but within those facilities, are there services and resources? So that comes down to, are there social workers that can help? Are there outreach in terms of community services if is identify a woman needs one? So these are the things they pointed out for the facility related. Then they talked about community related, and then it's more on thinking about the accessibility to resources, community-based organizations, and how do they cater to women of reproductive age. And one of the examples I have is for mine county, Guilford County, we have an organization called Every Baby Guilford. So looking at not only reproductive moms, but the babies as well. But these things, like how much are we using them? And that's the failure either from not having them or using them that leads to the community-related deaths. And this is in 2021. And then we come to the provider-related death, which is really important to us as we have this conversation. So now 73%. Now they broke this down into various parts. One, delay or lack of diagnosis, delay or lack of treatment or follow-up, failure to follow evidence-based standard of care, inadequate patient education or preconception counseling. Remember, in the beginning, I talked about the preconception counseling, and I pointed out to our primary care clinicians on the call that you are part of this spectrum. We need to educate. We need to talk about medications. We need to talk about all these things. We need to talk about optimization. And then one of the things that, as much as medicine is a science and an art, everybody can be an artist in different way, but we do randomized trial for a reason. So we want people to stick with randomized trial. There are times where, the person's not going to read a textbook. They're going to show up to you in completely different ways. And my best example I always say is think about the Hollywood chest pain. That's not how women present. So think about the patient, listen and talk, and then think about what the evidence show. Go for that first. I cannot stress enough that trust is built up in listening to the individuals that you care for, because you will be able to, and for you physicians on, I don't know the training of other people, but for you physicians on the call, you have been taught that at least 80% of what you're going to do with the patient comes from their HPI. Your physical exam supports it. Your testing is just there because you've gotten that information. Your high index of suspicion is from your HPI, and then you just follow everything. So stop and listen to the individuals. We've gotten so busy in terms of, I've got to go see this patient, and we just interrupt the patient and don't get the story, and then sit there and want to order this and order that and order that. We need to step back, because if you see the data here, 43%, that adds up to that 73% of clinician contribution. And lastly, here are the patient-related factors. So we need to, as we educate our patients, we have to also make sure that they understand what access are, they understand what symptoms mean, and they know where to seek help. Because sometimes we'll tell someone and they'll tell us yes because they want to maintain our integrity, but do they really know? Teach back to understand if the individuals have lack of knowledge. I also want to point out that the fact that an individual can read, speak English, or it has a college degree doesn't mean that their health literacy is where it should be. So we always have to not make assumptions and educate our patients. So we make sure all these things that have been labeled in your review there is really coming back. Do your part, and let's do all of our parts to make sure that women are cared for. Again, just like nationally, when you think about the data, the disparities again present in Black and white women. You'll see the numbers here respectively, over 100,000 women during that year, which is 2021 for 2024, 138 Black women versus 50 white women. And then you look down here again and thinking about cardiac related causes, the different causes that happen over that time. So 26 versus 5.8 and 15 depending on with COVID and none in our white counterparts. So there are outliers like homicide that happen also more in Black women versus their white counterparts. And then again, we looked at overdose based on that review. So we have work to do in terms of how do we care for women. Now, I saw this and I share this with you. Sometimes when I have these conversations, I bring this up because when we have conversations of possibilities, we have to forget about our political affiliations. We have to forget about sometimes our religious affiliations, and we come as objective human beings to have these conversations. So I saw this and I use it now just to spark that conversation when one of our senators said, you know, maternal death rate isn't as bad if you don't count Black women. So think about what that means to you as a clinician. Don't answer that question. I don't want to know how you feel about it. But what I want you to understand is when you look in the eye of a patient that may be Black, Hispanic, white, Asian, Southeast Asian, all you see is a human being. And that human being has a mother. That human being has likely a sister or brother. That human being comes from a circle of people. And if you walk away because you want to make your number different, please think about what social structure are you really destroying, and think about what difference can you make to make sure that individuals have the best care. And if they're postpartum and you're walking away without listening or caring, think about might potentially leave an individual a baby without a mother. So the data doesn't support this. I would hope that as clinicians, these are the things that we see and say, this is not what I want to do because of the oath that I've taken. Now, what else can we do? We have to be able to think about, well, that's one way to handle it, and move on. But what can we do? We have to be able, as healthcare professionals, when we witness the impact day after day, and I always say this, as healthcare professional, even if you're on the physician leadership side, you're on the administrative side, and but as long as you're in the healthcare, there will one day be a patient that goes with you. Regardless of, there will be a patient story that you may never forget, even if you never share with anyone else. But I always want you to think about the 5 whys, understanding root causes as you get into these difficult conversations and situations where you need to be able to either, it's an opportunity to have a conversation of possibilities and create solutions with people that you may not have the same alignment or mindset with. First, I want us to step back and look and do this exercise together. The 5 whys. So now you're going to think about, why does the United States have high maternal mortality rate? That's the first question we're going to ask ourselves. And then we already know the answer based on, like that those high rates depending on cardiovascular disease, infection, hemorrhages. And then we want to understand again, why does Black pregnant or birthing people have high death rates? Because we've seen that not only in the US as a whole, we've seen it with our data that we have in Virginia. Now you want to talk about, is it delay in reaching care? Is it accessing the care? Or is it diagnosis of stress? Then you want to go again and think about, why does Black women not receive appropriate care based on standards? And then you want to go and understand, what is that? Is it less access to overall care, not listened to by their providers? Then if it comes to, why does that factor disproportionately affect Black birthing people? You start getting to the meat and potatoes of what you need to do. Now you start thinking about, okay, structural racism, residential segregation, implicit and explicit bias. We all have them. I don't know. I don't care what you say, but the thing about implicit and explicit bias are how we react. What do we do with those things? Disproportionately impact the SDOH needs in Black women. And then your last why is really why. That really comes down to what we talked about. If you think about 2 slides ago, policies and practices. What's affecting healthcare today? Policies and practices. Policies of what put in place by the payers, policies of what put in place by our government, our local government, our state government, our federal government, policies and practices by our clinicians, right? Our physicians, our care team, our nurses, think about even our social workers. So these are the things that when we start breaking down and thinking about our whys, we can be able to take 1 or 2 things and say, well, this is what we find. We can be able to do something about it. We may not be able to do something about everything, but we can do something about one of those things. I just want to reflect and bring your attention to the differences between health equity and health disparity. Just making sure that we all understand that health equity is giving everybody what they need to achieve their outcome. Health disparity is that meaningful difference that make an individual disadvantaged. And most of it is surrounding the social determinants of health. What I want to share with you here is the misunderstanding of what equity is and equality is. Now, if you look across this playing field, you see the reality. You see here, this person has more than they need. The others can't see the field. And if you look here, equality, they give everybody the same exact thing. Well, that's not going to help anyone. Look at the lady here in a wheelchair. She can't see. And if you look at next here, now we're getting somewhere. We give everybody what they need, and we're all able to see the playing field. Now, if you start thinking about justice, will we get there one day? I hope so. But at least let's get to equity. Let's have better outcomes, and we can be able to care for people.
Dr. Todd,
Yes, ma'am.
we got a question in the chat.
Oh, of course.
Okay. It's from Dr. McIntosh. It says,
Mhm.
Good evening, everyone. Thank you for such an excellent presentation, Dr. Todd. With the ongoing obesity epidemic, would you recommend that women in the reproductive age group consider use of the new weight loss reducing medications if therapeutic lifestyle changes are ineffective prior to a planned pregnancy in an attempt to reduce maternal morbidity or mortality? Thank you.
Thank you. So, Dr. McIntyre, thanks for your question. So that is multifold. One, we have to look at the use in terms of the appropriacy. So let's say if they're a BMI of 40 and they have metabolic syndrome and especially prediabetes, yes, it is. And overall, there's good cardiovascular risk reduction information that we have, data that we have, but now we're limited by payers. So to answer your question, ideally, that's something that is very beneficial. But in the real world, it really depends on what's going to be approved. But yes, great point. Thank you. Is that Mary? Thank you so much.
Yeah, that was it. Thank you.
Yep. So what I want us to understand from here is making sure that we are looking at equity and not equality. I know individuals will say, I look at everybody equally, and that actually rings a bell in my mind as red flag. You have to look at each individuals and appreciate them for who they are, not only for their race, but for their personality and for their needs. And even when it comes down for those of us who have children, we can treat both the same because we have to understand what their specific needs are. So today I'm asking you to, if you are of the equality mindset, as a healthcare professional, I'm urging you to please start to consider the equity mindset. And then one day, as we do that, we can get to justice. But we're not there yet. So the social determinants of health I talked about earlier really impacts the outcomes that we do as clinicians. We do our part, but think about that one patient. And if you've never done this, I'm not pointing fingers, that you may have wanted to say they're non-compliant. You may want to say they are a frequent flyer in residence. If you're on the call, I'm really picking at you guys now, because by the time we get into fourth year and we get the residency, I don't know if we're jaded or we just kind of like got that repetition going, and we're easy after that call shift and say, oh gosh, she's back in and she's not compliant. Before you say that the next time, I want you to ask yourself, why is she not taking her medicine? Is it because she didn't tell me that she can afford it and I didn't ask her with integrity? Or him, why is he just coming back? Is there an issue in the wintertime? You see he's coming back. Does that person have heat? Before you say that, I want your mindset to really go to my voice and say, why did I not ask that person? Because there's always a story. And there may not. It may be health literacy where the individual may not understand that they need to take that medicine for a month, and they come back and we're like, oh gosh. And I am not going to be a saying I've never done it before. I have. And that's why I know that it's easy for us to do it. However, I have really learned to shift my mindset and understand that we can help our patients. We can help the people in our community, and we cannot do it alone. And we're going to have that conversation as we go along. So this is what happens. We are standing in the water and just pouring it back and forth on that individual. And this was supposed to be a video, but I couldn't get the video to play. And just pouring, just imagine this guy taking that bucket, trying to fill it. And I mean, he's draining in there. And sometimes that's our patients. And we have to think about how we can maintain their integrity, sit down. And when you ask those questions, you're not hovering over them over the bed and looking down on them. Take that minute, sit down and ask them those questions, that you can have opportunities to get social work involved, community health organizations involved, that we can be able to make a difference for our patients. Now, when it comes to maternal health, it's not any different. We need to make sure, because the social drivers of health, again, is one of the biggest factors why women are not coming for their visit, is one of the biggest factors that she may not be able to take her diabetes medicine. Is she under stress? Does she walk through the door and she feel that, I'm here, but this doctor doesn't want me here, or I'm in this area and it's just stressful because if anything I say is dismissed, are there are smoking issues, income, food security, thinking about language barrier, and one of the biggest things, because sometimes I appreciate the fact that most people in the United States speak English, and it's an expectation, but we have to understand that as the United States become a melting pot, as clinicians, the first thing is we have to recognize and understand if an individual can understand, or if they have identified another language, we make an attempt to either get an interpreter or do something that we can be able to communicate clearly with the individuals, because it impacts that life. Here's the financial burden on how it looks in our country, and I have the resources here and the references here for you. When it comes to homelessness, yes, women of childbearing age can be homeless, $1.5 million. And then it comes to thinking about lack of transportation. One of the reasons why someone may not show up, not because she didn't want to show up, is because she didn't have transportation. And we didn't ask those questions and we said no show. And sometimes that comes with a price. So now if I didn't have transportation, or the bus route is not on my way, and you charge me $50 or $60 higher difference, am I going to show? Because I don't have that amount. First, I'm having financial difficulties. So before we say no show, sometimes we should ask questions and understand the why. Now, people facing hunger. another reason. And if you look at the data, it's very it's really telling out there. So we have to be careful. Again, I emphasize that 80%. And this is data driven. It's not something that I like and say, oh, this is the number. No, this is data driven. And we all have to really pay attention on how we support our patients. So this is a problem. Now, is this a solvable problem? I like to think that most of it is solvable based on what we can do. How can we end unequal treatment? How do we take care of the people that are in our community? One of the biggest things that I see as a possibility and an opportunity is know your data. Are your clinicians aware of what the data shows? Or are you just saying, when it comes to clinicians, we're scientific people, we're data driven. We want to see the data, we want to know the data. Some may say, I don't care, but in order to change and be able to know what our gaps are, we have to know our data. We have to be able to first identify where the disparities are. We have to be able to direct our efforts to addressing the inequalities in the care. And a lot of people say, oh, we do everything, we're great. But once you start looking at your data, you'll understand that you may be doing your best, but your best may not be good enough. So it's not about punishment, it's about the opportunity. Now, how do we look at these data? You can't just pull it out and say, okay, this person lives here and this person lives here. I really want you to be intentional. Talk to your data people today. You want to understand race, ethnicity, and language. Because once you put it in that format and see the gaps, you're able to do something. Because someone who lives in a certain area of your service area may not need the same thing as someone else. Someone who is Caucasian may not need the same thing as someone who is Black and Hispanic, or vice versa. So once you do that, once you are able to locate your data, you'll be able to understand, well, these are the things that are happening in the pockets of our organization. One of the things that you're going to uncover, well, are there people in the organization that are doing things that are great? How do we learn from them? Is there a way that we can partner, or that redundant work? Well, how are we communicating? Is cardiology talking to OB, or when patients are referred, do we see all the information? How does the PCP really get to do their preconception counseling and then talk to the OB? So communication becomes very vital. Now, how do we do that? Because once we understand our data, once we go back and see that, how do we really start to make a difference? Is breaking down the silos that we've seen from our data, approaching each other, and also looking at those gaps that we found. One, we have to have communications. Because if the people in our community realize that we're not working together, they're not going to trust us. And if you think about, especially when it comes to racial disparities, most of it lies on trust issues. And if you've not seen this in literature, the father of OBGYN, if you think about the initial surgeries, they were done on Black women who did not have any sort of pain control. Hence, some of those preconception notions or biases that, oh, Black women can tolerate pain, or Black people can tolerate pain. So that's one. And you think more recently, you start thinking about conversations like the syphilis experiment, and all those things that have created mistrust and distrust, especially for racial ethnic groups, are important that we first mend fences, create trust, and trust comes from working together and also talking to our patients. Once you can do that, you can develop trust. I also want you to imagine that if you capture all these data and you cannot share it, you're not able to use it across the board, that does nothing for you. It's just data mining. So you want to make sure that everybody in the community that you serve, people that should have access, and you can be able to build infrastructures. Who's responsible? Pretty much everybody. Health systems are responsible, community-based organizations are responsible, and clinicians are responsible, care providers. And I intentionally put care providers here because that includes our social workers, that includes our community health workers, that includes our nurses, that includes our clinicians, that includes our physical therapists, that includes our lactation specialists, that includes everyone that will give care to that woman of reproductive age in any way, shape, or form. And sometimes it can even extend to the people that work in the kitchen that brings the food and the caring way, and they might see something and have conversation with that woman that it can extend to the other care team. So everybody's responsible. But the most important thing is, how do we work together? In order for us to do this and be successful, the key is partnership. You partner with me, I partner with you for the good of the patient. We talk about objective ways of how we care for the patient. And it's not about getting credit. It's not about, oh man, OB has done this and this is what we're going to do. It's about a common objective with making sure that the woman of reproductive age, that care is delivered and we're able to make sure. The other aspect of the partnership is looking at community-based organizations that align with your vision, mission, or just the objectives. You may not have the same mission or vision, but if you can align with the objectives of what the care is, because healthcare systems cannot do it alone for the social resources, we have to be able to work together with individuals. Now, healthcare system, what are some of the things that we need to strategically think about to make sure that we're getting there? One, we're focusing part of this talk on the social determinants of health, the social drivers, because we do have great clinicians, we have clinical care, but we need to adopt certain ways that we can be able to make sure that with that great medical care, the 80% can start to come along. We want to understand if there are screening platforms, how's your data is collected. Are you looking at social determinants of health in a different way? When you do that, are you referring individuals? How do we really integrate and implement interventions that we see from the data, the problems that we've really understood from the data to be able to create these interventions? Are we really intentional about making meaningful partnership with our community-based organizations? And most of all, cultural humility. The fact that you have a friend that is Black doesn't mean that you understand the Black culture. The fact that your best friend from college is Hispanic doesn't mean that you understand Hispanic culture. The fact that you're Black and your best friend is from Maine and they're Caucasian from Irish descent doesn't mean that you understand. We have to be objective and really be willing and open to be really get in depth of understanding what that means to the person, not what it means to you. What it means to the person and how that shifts the interaction that you have with them. So we have to be very careful about that. And one thing I also want to point out when we talk about people from African descent and talk about Black race in America, there are cultural differences. So, for example, since we're focusing on women, not all Black women are male alike. So you may have someone who is a Black woman that was born in the United States and grew up here. You have a Black woman who was born in Africa, a West African country, that come here and have adopted away, and you have a Black woman that is from the Caribbean or from Dominica. So you have to be very careful and think about, like I said, cultural humility and those cultural shifts that can really build or break relationships. Now, what can the community-based organizations do? First of all, engage in one that you're going to have meaningful relationships with, ones that actually are deeply rooted in a community. So you want to look at what are the local government doing? How do we partner? Faith-based leaders. Are you thinking about churches and synagogues and mosques, and you start thinking about business leaders, because schools and the hospital, public health departments, the reason why these are important because there are lots of time the grassroots of the community. So people will trust them. People will be, the leaders in this area are able to congregate individuals in the community, neighborhood organizations. You want to really invest in that and see these organizations as partners, because once you do, they're able to help with those social resources that we may or may not be able to extend as healthcare providers. The one thing you want to do, though, you want to be able to track that. So in terms of social determinants of health, if, for instance, you have a tool that you're using, you want to be able to make sure you're not just loading that, you're also getting data on where these things accomplished for individuals. Did we get the social needs that they care, just like we do for our healthcare? When we write a note and we share the note with, as a consultant, I share the note with my OB partners or the PCP. That's that 360 because they got out and I give them what they refer to me. I give them that information. So we want to be able to intentionally do the same things with SDOH. Now, come to us. we have to be intentional. Our actions have to really show that we're trying to make that difference. We have to prioritize. And the clinicians on the call, like, yeah, right, like I have time for my visit. You may not have time for the visit. However, but when you detect and you didn't have the conversation, you can send an information referral to your social worker, who that's what they may or do all day. They'll have time for those questions. When you think that they're not taking their medicine and you didn't have that conversational opportunity because you have 15 or 20 minutes or you're rounding and your rounding list is high, talk to the nurse and say, hey, I think this is something that's going on. Let's get that information. What's really important, though, that healthcare needs to understand is a diverse workforce. Now, you can say anything you want to say, but there are people from different backgrounds that actually are qualified. So if we're able, and there's a data that showed that, and this was a OBGYN, a surgical data actually, that when, first of all, gender, when women were taking care of individuals, their outcome data was pretty good. And then the data within a different study that was, I believe, 2022, when individuals of like race were taken care of by, for example, if a Black physician took care of Black patient, the outcome for that Black patient was better. And I just heard yesterday, and this is not reported in a data or any way, one of our nurse educator told me that she was on a webinar and there was data from one of our hospitals in North Carolina that said, based on the ID badge, and they had those detector things on it, when the nurse of that OB patient would go into her room and speak with her, the timing of the interaction was longer than when they were of different races. So it's important because the culture aspect is just a given, and people are able to have conversations and educations that may be either less intimidating or more intimidating if they're racial discrepancies. So what can we do? As we've talked about all these things, there are a few things that I'm pointing out. It's important that every member of the team, and yes, clinicians, I'm talking to you, all the physician residents, yes, you too, because if we can identify and we're able to help, think about when looking at residents, when you think about you have your med student, third year resident, you have your second year resident or your first year resident, you are the captain of that ship. If they see you asking those questions and understanding, they're going to likely do the same thing. And for the attendings, if you talk to your residents about the possibilities that there may be a factor and not just laugh and say, oh, they're not compliant, your resident will go with that information. And clinicians, if you don't have a resident, just step back and make a difference in that way, because you can write the prescription. If they don't take it, we have to understand why. So every member is responsible for this. Every hospital have a referral process is different, and I'm really hoping that your hospital do. Community health workers are now becoming really an integral part of the clinical care that bridges that gap between home and the facilities, and we want to make sure that we're utilizing that. We have to make sure there are reliable follow-up. Like I said earlier, you can't just put it in and move on and you've done a good job. You have to make sure your social workers are following and the individuals really do have what they need. Now, a few things that we can look at and talk about all day, because this is a conversation of possibility. Like I said, you can identify the racial biases in healthcare processes as you look at your process, communicating the values and commitment for equity, racial justice, and inclusion within your organization. You can also be able to promote educational opportunities within a workforce, like the conversations like this. So I really want to commend Dr. Moore and Mary, as well as Leslie, to have these type of real crucial conversations. The next thing, to improve quality of the cultural humility. I cannot stress it enough. And when we think about clinicians, and if some nurses here, I'm sure we talked about that. Nurses, you are the cornerstone of what clinical care does. I don't care what anybody says, because if you have a great nurse by the bedside, you're actually going to have really great outcomes. So I want you all on a call to take pride in this, that your training is important. You understanding what clinical humility is, cultural humility, is really important, because you really spend so much time with the patients in an inpatient. In an outpatient, it may be a different story, but that is important, and I want you all to know that. Diverse workforce, I mentioned that already. So now what am I asking you to do today? I'm asking you to do a few things. So this is the call to action of these 4 things. As you walk out of or turn off your computer and do what you have to do for the rest of the day and into tomorrow, I want you to pick one thing that you can talk about as you go along. Are you going to change the narrative? I understand we can't do it all, but one patient at a time. If your narrative is frequent flyer, if your narrative is non-compliant, if your narrative is no show, I want you to step back before you say that. You use it, you figure out those 5 whys. Why am I calling this patient a frequent flyer? Get that answer. I want you to be able to have the conversational possibilities without blames, but solutions. I want you to be able to think about those partners that within your organization, your service lines, and the community. How can we work together? Who can I do this with? And then our grassroots, the data. Please collect data. Let data be your guide because you can say what you want, but if you have the data to have the conversation, you have possibilities. The other thing that I want you to do is really weave in prioritize equitable interventions for unmet social needs because they impact what we do. Please leave here today asking this organization, where are we now? Because that's very important. I thank you. So thanks, everybody.
Thank
I
you.
will be happy to take your
Thank you
questions.
so much. I'm
You're
sorry. I'm sorry.
welcome.
That was excellent. Anybody have any questions for Dr. Toad? Anyone?
You can ask your questions, make a comment if you do not agree or you have, I'm open to answer your questions. And like I said, this is a conversation that we have to have and we need to do that.
Dr.
It's even,
Tobin, it's
yes.
Dr. Moore. I just wanted to reemphasize something you mentioned in your talk. Oh, that is to the residents on the call, please be aware that it's not just the residents, it's all of us. Each of us is a role model for others in the clinical setting. So when we are dealing with patients, as she mentioned, it's so important that we basically utilize the ways for communication, particularly trying to learn about the cultural preferences of the patient, that we need to ask them what their preferences are and try to, if you will, adapt in a way that will enhance and facilitate and promote the situation they find themselves in. So each of us is a role model, and it's so important what she was talking about this evening as we all work with patients every day. Thanks.
Thank you, Dr. Moore. I'm sitting here smiling and see that I just confuse everybody or everybody understood what I'm saying.
I think they did.
So, oh God.
Any
I really
questions? Anyone comments? Complaints or concerns, as I usually tell our residents after we have a session?
I think we're just gonna charge everybody with getting back with us by the end of the month what they have been implementing.
Leslie, any final comments, and
Yeah.
we'll float our tent then?
No, I thought it was all excellent. One of the things that kind of struck with me is that in our area, we have at least we have a really close relationship with the local FQHC. In our residency clinic and in the FQHC, we see a very high population of high risk moms to be. And it kind of struck me what you said was getting our moms to the point that even before they become pregnant, they really think about that prenatal counseling. And I'm sitting here thinking about how do we, create structures or processes or community outreach or even information in our primary care practices that we plant that seed or get them engaged. And what does that look like that they begin to think about that even before conception occurs? That's what kind of struck with me. How do we help our providers engage our moms before that, so that they can get healthy, because we do have a high level of obesity and hypertension and diabetes, and other things that are going on, so that we can help them have the healthiest and best outcome possible.
Mm-hmm. Yeah.
I wish that I don't think Dr. Paler is on the line. She's our FM OB faculty, and she's working with our team to try to create some or strengthen quicker response at our ED for when moms have delivered and they come in to the ED with kind of elevated blood pressure, so that we can identify the eclampsia or concerns around that a little bit quicker. But lots of things going on, lots of good work, but very, very timely.
Any final comments or questions from anyone? Well, Leslie, let me thank you for moderating this. Dr. Tope, thank you so much for your time
You are welcome.
in developing the program. We greatly appreciate your efforts and your being with us this evening. I will try to pivot on what Leslie just mentioned to you about being aware of prenatal moms, particularly with elevated blood pressures. In 2 weeks, we will have Dr. Phil Honea and one of our residents helping with his presentation on elevated blood pressure in pregnancy and preeclampsia, and God forbid eclampsia itself. So hope you'll be with us in 2 weeks. As I mentioned to the residents each time I gather with them, please be careful out there, and we hope you'll see you back in 2 weeks. Take care and have a great evening. Good night and bye-bye.